So let me talk a little bit about what happens in post-acute care. So the next slide will show you 3 different pathways that patients usually take on their way to discharge from a hospital. The first one is the skilled nursing route, and I'm going to lump in there skilled nursing facilities and rehab facilities at the same time. My experience in this particular area has come most recently from the 4-year and now extended to 8-year RAVEN initiative. RAVEN stands for Reducing Avoidable Interventions in Nursing Facilities. So we've had significant experience in working with skilled nursing facilities to try to return persons to the community, but also if they're staying in skilled nursing, to try to have them stay in the skilled nursing facility and have all of their needs met. And I will go through that example in significant detail, and while I realize that so many of you are involved in pathways B and C, I think it will be illustrative, and I will try to move quickly to B and C so we can have more conversation about what happens in the practices where you are mostly involved. The second pathway is fairly traditional in terms of a patient going to their home. They would receive additional interventions from home health with the expectation that their primary care physician will be the one who will be taking care of them once the course of home health is completed. And the third pathway is a patient who goes from the hospital directly to home. There is no home care. The expectation is that they would follow up with their primary care physician. For pathway B, Pittsburgh Regional Health Initiative participated in an initiative through CMMI, the Centers for Medicare and Medicaid Innovation, called the Primary Care Resource Center, which allowed us to take care of certain patients with chronic conditions post-discharge, put an entire team around them to try to help them transition to the community, and we learned a lot from that initiative that I'll share with you. And Pathway C, we are very involved through Pittsburgh Regional Health Initiative in the practice transformation arena, where we are helping practices now be prepared to use better communication tools and better communication with their patients and providers to make sure that patients are picked up post-discharge, taken care of well in the community, and only return to the hospital when that is the best opportunity for them, and that is absolutely necessary. I want to be really clear here. I don't believe that every hospitalization is bad. I don't believe that every rehospitalization is bad. I do think that there are many opportunities that we have to reduce those hospitalizations that are preventable and to have an early warning system for all hospitalizations that would allow us to better use the resources appropriately to keep people where they most want to be, which is in the setting they were discharged to, whether they chose skilled nursing, rehab, or home. What is disruptive to them is when they are sent to a particular setting and then they are bounced back to the hospital because something went wrong. If they know that they're on a trajectory such as Pathway B that has 3 settings, and we do that well, they get a good outcome. But if we bounce them back and forth to the hospital, we are often compromising their health and certainly their financial well-being and that of those of us who are ultimately going to be penalized for those readmissions as well. Next slide. So regardless of where you end up, whatever setting you end with, we see that there are 7 key elements that can be used to reduce hospital readmissions and improve the coordination of care post-discharge. And I'm going to go into some detail on these. They are slightly different depending on the setting where a patient goes after the hospital, but essentially a lot of this work starts in the hospital, and it is information that would be very valuable in the hospital setting to be used for coordination of a patient post-discharge. So you can see the 7 that are on the list there. Next slide. And before I get involved in those, I understand that many hospitals and skilled nursing facilities are involved in transition care models. Over the past 10 to 15 years, a number of models have been developed, they've been researched, and they've been implemented. I'm not here to tell you which one of these I consider to be the best. I am happy to tell you that they all have common elements, and it's those common elements I'm going to be discussing today, but we'll very quickly run through these slides so you can see the 4 different models, and at the end of the presentation, I promise you there is a link to each one of these for you to do a deeper dive. So next slide. This is the Reengineering hospital discharge model. I have no expectation that you can read the small print on the screen, but this was an AHRQ-funded intervention that redesigned hospital discharge and used a nurse as a discharge advocate for the patients. Next slide. This slide, which is the transitional care model, it is also a nurse-led care management model, and it provides in-hospital planning and home follow-up for chronically ill patients, particularly older adults. The third model is the care transitions model developed by Dr. Eric Coleman, and it has similar elements as well. You can see self-management, PCP follow-up, alertness to red flags. Next slide. And the fourth model is the BOOST model, called Better Outcomes for Older Adults Through Safe Transitions. And my purpose in showing you these slides as quickly as I did was not so that you would be speed readers, but so that you would understand that there are tremendous resources out there. This is not an issue that is brand new to the scene. It may be new to your practices and how you are looking to redesign your care, because up until now, there hasn't been any negative recourse to readmissions, but there have been some wonderful people working in this field for the past 15 to 20 years. There's a lot that we can learn from the work that they have done that has gone before, so that your individual institution does not have to start from scratch in developing tools and trying to figure out if there is a solution to this problem. There are solutions, plural, to this problem. You'll have to identify which ones work best for your culture and your organization, whether you're a large organization or rural hospital. But some of the key elements are what I'll be discussing, and then you can assess where your organization fits relative to each of these models.